All right, well, good afternoon, everyone. It's a pleasure to be here talking to you about the cath coding portion of the boards. Thanks for sticking through. It's getting close to the end of the day. I'm sure you're all getting pretty tired here, but this is a key part of the boards, and we'll be going through a lot of different angiograms, and what I'd like to do is share with you a simplified way to interpret coronary angiograms that will help make things as fast and easy as possible for you on the boards. And we'll also talk about just some coding techniques as well to get you prepared. So the key learning objectives are to know the angiographic view, to know the myocardial walls that correspond to a specific area in the angiographic view, know the coronary arteries, and then to know the key diagnoses that you are expected to know based on the angiogram. So the first thing I like to do is orient myself to the view. Is this an RAO, LAO, based on anatomic landmarks? And then it's key to also understand the coding sheet and know what's on that before you take the exam so that you can quickly code what you need to. Don't overread angiograms. It's a key thing, and really think about the cases clinically and think about, well, what would I do in practice, and that will usually take you into the right direction on the boards. And also know what normal is, because there probably will be a normal angiogram or two on the boards. So this is the coding sheet. This is a revised coding sheet in the last 2 years. And note that this is only coronary anatomy here. So we're only coding coronary anatomy and pathology. There's no left ventricular grams or aortograms in the coding portion of the boards. And really, you're expected to classify stenoses, fixed stenoses, as either insignificant or mild at 50% or less than 50%. Moderate is 50 to 75%. Severe is greater than a 75% stenosis. And a complete occlusion would be 100%. And then you can note which vessels are filled by collaterals. And you can see the columns are the left main, LAD, circumflex, right coronary. And then you can also code any findings that are in a bypass graft if that happens to be shown. And you can see all these different diagnoses: myocardial bridge, fistula, ectasia, and then you can also code where the bypass graft goes to, LAD, circumflex, or the right coronary. And whether or not a stent is present. You should look for stents on angiograms, and you can note whether or not they're patent or occluded. So the first goal is to get oriented to your angiographic view. And the first thing is, where are the ribs and where's the spine? So you can see in the RAO view, right anterior oblique view on the left, the ribs are going down and to the right. So that's something you should remember. The ribs are going down and to the right in the RAO view, and the spine is on the left. So the spine is on the opposite side of the view that you're looking at. So LAO, left anterior oblique, the spine is over here on the right, and the ribs are actually going down to the left. So those are some quick landmarks that you can use to identify which view you're looking at. And once you know the view, then you already have an idea of what you're expecting to see in that view. So right anterior oblique, this is a LV gram. You can see that in the RAO view, you really are separating posterior on the left from anterior on the right. So the anterior wall of the ventricle is up here, anterolateral, apical, and then the inferior posterior wall down here. So even if you don't have the LV gram and you're just getting ready to shoot the coronaries, then you already know that the anterior wall is up here, so you'd expect the LAD and diagonals up here, and then the inferior wall is here. So these are the arteries superimposed on that same view. LAD diagonal, LAD supplying the apex, and then the posterior descending artery down here on the inferior wall. Similarly, the left anterior oblique view, you can see similar anatomy, but of course the LAO view is separating more of a left from right. So you have the lateral wall here, the patient's left side, and then the septal wall here. Anterior is up here and inferior down here. So it's really like a short axis view on your echocardiogram. And then you can apply that when you're doing your LAO angiograms, either the LAO cranial or LAO caudal. So here's the coronary anatomy superimposed on an LAO view. The left main is the first thing that your catheter will opacify, and then your LAD septal perforators will come down this way towards the interventricular septum, and lateral left circumflex over here, and the PDA will be down here. This is probably the best view to determine dominance. If a patient has a left dominant circulation, you should look in the LAO view to confirm that, and you'll see the LAD and the PDA in the same plane in that view. So if you know the view, then you'll know the walls, and then you'll know the arteries that are corresponding to that territory. Here's the right coronary. This is an example of normal coronary arteries. This is a right dominant circulation. That's present in 85% of cases. And you really want to look at the inferior wall to determine the dominance. Here's a nice LAO caudal view. You can see the patient has a mitral prosthesis, but this is actually a left dominant circulation because the left PDA is coming off of the circumflex, and it's in the same plane as the LAD. Here's the LAO cranial view in that same patient, and you can see that same phenomenon of the LAD, and then right below it is the left PDA. So these are normal coronary arteries. On the left-hand side here, you have a right dominant circulation, and over here you have a left dominant. Here's another example of normal coronaries. This is an areocranial view. This patient also happens to have tortuous coronary arteries, but that's not on your coding sheet. You can see the lumen is smooth. There's no irregularities that would suggest underlying atherosclerosis. And the same patient with an areocaudal view, you can see areocaudal helps open up the circumflex, so it's a good view for the circumflex and proximal LAD, whereas the areocranial is a good view to see the proximal, mid, and distal LAD primarily, whereas the circumflex is relatively foreshortened in the areocranial view. Here's another example of a normal left system. This is an LAO-cranial view of a patient with normal coronaries. LAO-cranial is a nice view for the left main and also the LAD, predominantly the proximal LAD and the origins of the diagonals. LAO-caudal is a good view for the left main and the bifurcation, so the proximal circumflex and the proximal LAD. So here's a question for you. You have A or B, so which of these vessels is the LAD? Is it this one up here, or is it this one here? What's your answer? And I'm showing you the video as well. The key here is to look at the movement, and the LAD will move independently from the OMs and the diagonals. Since the LAD is on the interventricular groove and really on a different area of the myocardium, it's going to move differently too. So if you're confused about which is which, that's something that will help you to differentiate the LAD from the obtuse marginal branches or the diagonals. So here's a normal right coronary artery. This is the RAO view, which shows you the mid-right coronary artery well. And you can see that the ribs are going down and to the right, so that's how you know this is an RAO view. Here's an LAO view. The ribs are going down and to the left, so that's how you know this is LAO. And the LAO shows you most of the vessel here. And you can see it's smooth with no stenoses. So here's a still frame image, and based on knowing where the walls are and what the view is and where the coronaries are, you should be able to tell then where's this bypass graft going. So go ahead and answer this question. Where's this bypass graft going? All right, good. So most of you got this right. And the key here is that this is an LAO view. Your spine is on the right, so this is an LAO view. So you're expecting that this is the lateral wall of the left ventricle, and the inferior wall is down here. So this is in the inferolateral territory. So then that would correspond to this left circumflex in most cases. So most of you got that right, and I think the key is just knowing the view and knowing that the lateral wall would be here, inferior wall here, septal wall over here, and anterior up here. So here's another example of a bypass graft, and I'll let you go ahead and answer this one too. So where is the bypass graft going in this patient? And go ahead and use your audience response. Excellent. So yeah, most people got this right. So 89% of you. So the LAD, it looks like the LAD. And it also, so there's several clues here. One is that this vessel has what looks like septal perforators coming off at almost 90-degree angles. So that's a sign of the LAD. But the other key thing is this is the RAO view. The ribs are going down and to the right. You can see that sternal wires are to the left and the spine is also to the left. And that this artery really supplies the apex. It wraps around and goes even a little bit into the inferior apex. So that's the LAD. Here's another bypass graft. Go ahead and answer this. Where is this graft going? Excellent. So good. So this is the LAO view. The spine is to the right. And now we're assuming that this is a right dominant circulation because it's going to the inferior wall. But the other clue that it is a right coronary is that there's also some retrograde flow, and you can see a diseased right coronary up here. So the right coronary would be your right answer here. So if you know the view, you know the walls, and you know the arteries, then you'll know where the grafts go. Now let's talk about collaterals. That's going to be on the coding sheet too. So where are the collaterals in this case? This is some still frame images that you can go ahead and take a look at these two views in the same patient and determine where are the collaterals going. Excellent. So this is an angiogram where the right coronary is being engaged and injected. This is the LAO view. Spine is to the right. Ribs are going down to the left. So you can see the right coronary filling, and you see collaterals coming from this acute marginal branch and also the distal right coronary and coming over to where the LAD should be in the LAO view. Similarly, you look at the RAO view where the ribs are going down to the right, and you can see that there are collaterals coming to the anterior wall and the apex. So that's how you know this is the LAD that is receiving the collaterals. Here's an angiographic video here. Go ahead and make an answer here. Where are the collaterals going? Good. So these are collaterals from the proximal right coronary to the mid and distal right coronary artery. So you have a chronic occlusion in the mid-right coronary. Most of you got that. All right, here's a still frame. And keep in mind on the boards you can get either videos or still frames. So you should, that's why we have both of these in this presentation. Where are the collaterals going here? Go ahead and answer. Good. So you see the left coronary being filled in this RAO view. You can see the ribs are going down to the right. You see the LAD filling and going down to the apex. And you notice that the circumflex is occluded here. You just see an abrupt cutoff of the proximal circumflex. And then you see this faint filling of an obtuse marginal. And that's how you know the collaterals are going to the circumflex. So a couple of clues there that the collaterals are going to the left circumflex. Here's a video, and see if you can tell where the collaterals are going here. Yeah, and I think this is a trickier one. That's reflected in the answers here. I don't know that this would probably come up on the boards because it is a little tricky to tell, but this is probably going to the left circumflex. This is the lateral wall of the ventricle, and just the appearance of it is consistent with an obtuse marginal collateral. So I would have coded circumflex here. But I think it is a little bit of a tricky question. Probably wouldn't have this on the boards. All right, here's an example of collaterals going to the posterior descending artery. You can see the LAD being injected, a large septal, and this large arcade of septal collaterals going to the posterior descending artery. And keep in mind on the coding sheet, you'll have to know what the dominance is to code that, because it's either going to the right coronary or the left circumflex. So you'll have to have more than just one view in most cases to be able to code that. So if you know the view and the walls and the arteries and where the grafts go, then you can also know where the collaterals go. So it's really adding up all those things in a stepwise approach. Let's talk about coronary anomalies. So we should suspect coronary anomalies in patients who've had sudden death. Whenever you see a long branchless origin of a coronary artery, that's another clue that this could be a coronary anomaly. So just keep that in the back of your mind. And then also you need to be able to distinguish the left versus the right cusp of the aorta, of the aortic root, in order to determine where that anomaly is coming from. And then also to distinguish anterior from posterior when you're looking at the aorta. So it's really going back to those views and knowing anatomically what is in that view. So let's talk about that. So with coronary anomalies, we have to be able to distinguish left versus right, and that's going to be in the LAO view. So you'll have the left cusp over here and the right cusp over here. This is a JL4 diagnostic catheter in the left main. You also have to be able to distinguish anterior versus posterior, and that's going to be in the RAO view. Anterior is going to be over here, where the ribs are going down, and then posterior will be towards the spine. So here's an example of an aortogram showing that specific thing, where you have the left cusp over here and the right cusp over here. This is the LAO view. And then in your RAO view, you have the non-coronary cusp, or the posterior area of the aorta, and anterior. And this is particularly important when we're looking at what the initial course is of the coronary anomaly, which we'll talk about here in one of the next slides. So with coronary anomalies, I like to simplify this into a few basic concepts. So you can have a posterior course of the coronary artery. So this is an axial view of the heart. So imagine you're looking at an axial CT slice of the heart. You have the pulmonary artery anterior, and that's closest to the sternum up here. And then the aorta is, of course, posterior to the pulmonary artery. So if a coronary anomaly is going posterior, then that tends to be a more benign anomaly. So going from the RCA posteriorly. You can also have it coming off the left cusp going posteriorly as well. But then you can also have the inner arterial course, and these are the ones that are more concerning and can be associated with sudden death. So we can see all that also just based on the angiogram. This is a patient with a coronary anomaly. You can see the LAO view over here, and you can see it's originating from the right cusp, and then it's going over to the left. And this has the appearance of the LAD. Over here, in the RAO view, which distinguishes posterior from anterior, you can see that the initial course of this anomaly is going more posterior towards the spine rather than this way, which would potentially signify an anterior course. So this is a posterior LAD anomaly that's coming off of the right coronary cusp. Here's some other examples of coronary anomalies. And this is an anomaly that you see when you're injecting the left main. You also see this other artery filling and coming off of the left cusp, and then feeding what looks like an RCA, a right coronary artery, in the LAO view. And then when we look in the RAO view, we see that the initial course of this is actually going anterior, and it also looks narrowed. And so that's concerning, as the course of this goes between the two great vessels, and that is at risk for sudden death and ischemia. Here's another example of coronary anomalies. This is an LAD coming off of the right cusp. You see both the right coronary and the LAD filling in this LAO view. And this is the same patient in the RAO view. And it actually has an anterior course. You can see that the anomaly moves anteriorly, and it never goes posterior first. And this is that same patient, and this is their axial CT. And you can see that that artery was going between the pulmonary artery and the aorta. So here's another example. This is one of the most common coronary anomalies. This is an anomalous left circumflex coming off of the right cusp. You can see that it originates in the right cusp, has a long branchless origin, and then wraps around and supplies the inferolateral and inferior wall. So this is also left dominant circulation. And the initial course of it in this RAO view is going this way, so it's actually going posterior initially. So this is a benign coronary anomaly. So let's talk about atherosclerosis. And basically, we need to keep in mind that the stenosis severity is going to be relative to the proximal vessel. And for the boards, these shouldn't be vague. We're required to classify them as complete occlusions, severe stenosis of greater than 75%, moderate of 50 to 75, or insignificant, less than 50%. Also, make sure you look for stumps, arteries that just end right at the beginning, because those can be missed. And make sure you look for all the branches that you expect to see, particularly if there's a part of the myocardium that is not getting perfused on the angiogram. And code the most severe lesion. So if you have a 20% and a 70% stenosis or 80% stenosis, you're going to code severe stenosis in the LAD. You're not going to code the 20% stenosis. And here are some examples. This is some examples of complete occlusions here. This is a complete occlusion of the left main here. Here's a complete occlusion of the left circumflex where there's an abrupt cutoff. Here's an example of mild disease. There's no stenoses that are 50% or more in this right coronary artery. And here's an example of severe stenosis of the LAD and diagonal. Another key thing to be able to recognize is thrombus. And there typically will be historical clues in the history, particularly in acute coronary syndrome, someone with recent onset chest pain. And the angiographic clues are dye hang-up, staining, or an abrupt cutoff, particularly a flush occlusion with a hazy stump. So here's an example of a patient with an inferior STEMI. You can see that there's dye hang-up in the distal right coronary artery in this LAO view. And there's also a relatively abrupt cutoff there. So that, for this patient, you would code thrombus and complete occlusion of the right coronary artery. Here's another example of thrombus. abrupt cutoff of the LAD in this ariocaudal view. Here's a thrombus in a graft where you have a luminal defect, almost a filling defect, and a hazy stump in this graft. So it looks like a vein graft. Another thing to recognize is dissection, and typically that will appear as a linear lucency, but it can also be more of a diffuse, smooth narrowing, particularly in patients who have spontaneous coronary artery dissection. And some clues to that diagnosis would be patients who have otherwise normal coronary arteries in other territories with no evidence of plaque anywhere, particularly women less than 60. And these can be either iatrogenic or they can be spontaneous. Here's an example of an iatrogenic dissection. This patient was having endothelial function testing with acetylcholine infusion. You can see the guiding catheter is deep-seated in the LAD, and progressively the patient developed this dissection that progressed into the LAD. You can see a linear lucency in the proximal LAD and reduced flow. So for this, you would code dissection of the proximal LAD. Here's another example of a woman, 37-year-old woman, who presented with acute chest pain, and she has more of a diffuse narrowing of her LAD. You see the ariocaudal view. You see this diffuse, smooth, relatively smooth stenosis of the LAD. And you can see it actually extends all the way from the proximal LAD all the way down to almost to the apex. And you can see how large the LAD becomes down here where it's not affected by that dissection. So this is an example of spontaneous coronary dissection, or SCAD. And some things to look for in SCAD would include tortuosity of the coronaries. Here's some severe tortuosity where the RCA makes a big loop. And patients can have other things too, like irregularities of the coronary that almost look like fibromuscular dysplasia or microaneurysms. So if it's a young woman who has known fibromuscular dysplasia and lack of atherosclerotic risk factors who presents with an ACS, you should think about spontaneous coronary dissection. Another thing that can come up on boards is spasm. And think about this, particularly if a drug intervention is performed, patients who get acetylcholine to provoke spasm, or patients who are given nitroglycerin to resolve the abnormality. This happens to be an acetylcholine infusion. You can see the microcatheter and the Doppler wire here. And this is the LAD before and after spasm. The caliber dramatically reduces. Here's an example of myocardial bridging. And this is probably the only diagnosis that they would show you a frame of in systole and diastole. So if you see systole and diastole, think myocardial bridging. And this is basically when you have an intramyocardial segment of the artery that has compression during systole. And this is usually going to be affecting the LAD, and it's actually common in patients with hypertrophic cardiomyopathy. Coronary aneurysms are defined as 1.5 times the diameter of the reference vessel larger. So when you see an enlargement distal of the vessel from the proximal vessel, that's a sign of an aneurysm. These can be associated with atherosclerotic disease or connective tissue disease. These are prone to thrombosis, ischemia, and embolic complications, as well as rupture. And here's some examples of coronary aneurysms. Here's a fusiform aneurysm of the proximal right coronary artery. Here's a saccular aneurysm of the left circumflex. Another saccular aneurysm over here. And you should also consider the possibility of endocarditis and sepsis when you see these in patients. So think about that as well if it's relevant in the clinical STEM and also in your patients. Coronary fistulas can present with a continuous murmur on physical exam, and these can be congenital or acquired. Most arise from the right coronary artery, but they can also arise from the left in 40% of cases. And they can terminate in a variety of places: the right ventricle, right atrium, pulmonary artery, superior vena cava, and coronary sinus are the most common places. And these can result in steel and ischemia. Here's some examples of the right coronary artery fistula going into the pulmonary artery. And one of the signs of this is when it's going outside of the expected cardiac silhouette. So it still goes back to the basics of knowing the views, knowing where the walls are in that view, and then you can tell if a vessel is going outside of the cardiac silhouette. Here's an example of the LAD to the pulmonary artery. You can see this RAO view that the pulmonary artery is typically right here in the RAO view. It's an anterior structure. And so you see this unusual vessel going superior off of the proximal LAD, and that's going to the pulmonary artery. Here's another large AV fistula. This is a massive fistula from the right coronary artery going to the coronary sinus. And the way you know that's the coronary sinus is that you see the right atrium filling first after this is injected. So for our coding sheet, it will only include coronary angiograms. There won't be any aortograms or ventriculograms. Images, though, may appear as part of other questions. So I will go through some aortograms and left ventriculograms for you for the rest of the boards and also for your clinical practice, as these are still indicated in many situations. So here's an example of a normal left ventriculogram. We typically do biplane left ventriculograms, and that really helps us see as much of the myocardial walls as possible. You can see this patient has good wall motion, and they have a typical cavity shape in systole and diastole. And one of the key things is that you should only see the left ventricle and the aorta when you do an LV-gram. If you're seeing other structures, then that's a sign of pathology, such as mitral regurgitation or other pathology. Here's an example. These are some still frames of an abnormal LV-gram in systole. You can see that this ventricle is not obliterating as much as it should. And they typically would show you diastole and systole, and then you could say that this patient has a reduced ejection fraction. Here's an example of a hyperkinetic ventricle with almost complete cavity obliteration. So this person has probably severe hypertrophy of their ventricle. Here's an example of an abnormality, and I'm just going to let you take a few seconds to think on your own what this is. And this is the best view to diagnose this abnormality, the LAO view. You can see the ribs are going down and to the left. So you have the anterior wall, the lateral wall, the inferior wall, and the septum. You have this communication across the septum. So this is a VSD with a left to right shunt. And so this is the right ventricle filling here. You see that there's only flow in systole. So here's another thing we can see with an LV-gram. This is an example of a true aneurysm. Think about this in patients who've had a prior myocardial infarction, hypertrophic cardiomyopathy, or Chagas disease. And you'll see an akinetic or dyskinetic segment of the myocardium, and the base will be wide. Here's another example. This is an example up here of an aneurysm affecting the anterolateral wall of the anterolateral wall in this LV-gram in the RAO view. And then down here, this is an example of a posterobasal aneurysm from an inferior MI. You can see this RAO view. You have the inferior wall here, anterior wall here, and the apex over here. This patient also has mitral regurgitation, and you could infer that this is probably ischemic MR because of their prior inferior MI. And I would quantify this as probably moderate MR, since the density of the LA never reaches the density of the LV. Here's an example of a pseudoaneurysm. This is a pseudoaneurysm right here. You have this narrow neck and then a cavity over here. So we're looking for this in systole, and there is a rupture rate with these, although we don't know a lot about the natural history of these. Up to 30 to 40% could rupture without surgery. Here's another example of a pseudoaneurysm in the anterolateral region of the left ventricle. Here's an example of apical thrombus. You see this patient has severe LV dysfunction and then this circular filling defect in the apex. So when you see that, think of apical thrombus. Here's a patient with Takotsubo cardiomyopathy. They have a hyperkinetic base, but akinesis of the apex and sometimes also the mid-LV wall. These patients will typically have a history of recent stress, either a medical illness in the ICU or emotional stress, and will have relatively normal coronaries, or at least no culprit lesions to explain this. So when we're grading valvular regurgitation, we use Seller's criteria. So that's how we just graded the mitral regurgitation. So grade 1 is partial fill of the upstream cavity. So either the left atrium or left ventricle or whatever you're looking at, the right atrium. Grade 2 is complete fill, but less dense. So the left atrium fills completely, but it's not as dense as the left ventricle. And grade 3 is that it does reach the same density, but it takes 4 to 5 beats to reach that density. And grade 4, or severe regurgitation, is it reaches the same density of the distal chamber within 3 beats. And it's the same for aortic or mitral regurgitation. So this is another case here of, I would say, moderate MR in this case that we're showing you. And keep in mind that you'll be looking posterior, of course, to the ventricle. So the RAO view is the best view to detect mitral regurgitation when you're doing a left ventriculogram, just based on the structure or the location of the left atrium. So if you do see contrast going back posteriorly, that's abnormal, and there is mitral regurgitation in that patient. Here's an example of aortic regurgitation. Here's an aortogram. This is only a still frame, but you can tell there's aortic regurgitation because there's contrast going into the left ventricle in this LAO view. Whereas here, this patient does not have aortic regurgitation because there's no contrast going into the left ventricle during injection. Here's some examples of other aortic pathology that you can see on an aortogram. On the top left, this is an aneurysm involving the aortic root and the proximal ascending aorta. Here's an aneurysm more in the proximal and mid-ascending aorta. Over here, you can see a coarctation just distal to the subclavian artery, and you see a hypoplastic left subclavian artery as well. And then here's an example of aortic dissection where you see dye hang up within the wall of the aorta. Some other things you can see that could come up potentially on boards are evidence of pericardial disease. And one of the key things is constrictive pericarditis occasionally will have distal epicardial fixation of the coronary arteries on angiogram. And you can see how the distal coronaries here, both in the right RAO view and the LAO view, are very immobile. And you can tell that they're fixed to the pericardium. That's an indirect sign that there might be constrictive pericarditis. And I just wanted to show you this left ventriculogram. This is a patient with apical hypertrophic cardiomyopathy. This is an RAO view. Ribs are going down to the right. And you see this, this is a transeptal Berman catheter going into the LV. And you only see this proximal portion of the LV, the base of the LV, and it's almost completely obliterated here, and then you have an apical pouch, but no obvious thrombus there in the apical pouch. And here's another example of a ventricular septal defect. This is another LAO view, but this is probably an iatrogenic ventricular septal defect, just inferior to this aortic valve replacement that was done. You see this very small amount of shunting in the region of the LV outflow tract from the left side into the right side there. And that's a little bit more subtle there, but you can appreciate that, hopefully. Here's an unusual detection of pathology here. This is a patient, elderly woman, presenting with an inferior ST elevation myocardial infarction. And acute onset severe chest pain, but the right coronary could not be adequately engaged. And does anyone know the diagnosis? You want to call it out? Good, yeah. So several of you have already diagnosed it. That's pretty fast. So dissection, you see this huge flap in the ascending aorta going back and forth. And that dissection probably resulted in occlusion of the ostium of the right coronary and the inferior STEMI. So just to go back to our coding sheet, now we're going to go through some individual cases. So I'm just going to go back to the coding sheet. You can reorient yourself. You have the different, keep in mind that normal is up on top. So if you see something that you can't find anything wrong with, just code normal for that. And then all the different coronaries are up here on the top in the columns, and then bypass grafts. The different pathologic findings are in the different rows here. So with that, we'll go through some of these cases. This is our first coding case, and I'll go ahead and play both of these and let you take probably about 10 to 20 seconds to answer these on your own, and then I'll show you what I would code these for. All right, so these are two views, obviously in the same patient, and what we're looking at here is an internal mammary artery graft. We're injecting into the left subclavian. Actually, initially we're from a transfemoral approach in this view on the left, which is an REO view, and then in this view, which is more of an AP or LAO view, we're actually coming from the left radial and injecting that same vessel. And what I coded was a lima to LAD, so a bypass graft to the LAD, and then a severe stenosis in that graft. So this is a severe stenosis in the ostial internal mammary artery graft. Here's another case. I'll give you about 10 to 20 seconds on this one. Remember, the key is to code the most severe lesion that you see in any particular vessel. This patient also happens to have an aortic bioprosthesis as well, but that's obviously not something that we'll be coding. We're only coding the coronaries in these, on these coding sheets. Good. All right. So I had interpreted this as an insignificant stenosis in the left main. You can see that there's a little bit of osteal disease in the left main that's a little bit hazy in this LAO view, but here's a zoomed up picture, and you pull back the catheter, and there's plenty of blowback there. So I didn't even think that it was 50%. And then there's also insignificant disease in the LAD in the left circumflex. Here's another case. This is an areo-caudal view, left coronary injection on the left, and areo-cranial view on the right-hand side. All right, so for this, the most important thing is that there's a severe stenosis in the LAD. And I think it's pretty hard to see that there is a stent in the left circumflex here. And I think it would be more obvious on boards. But if you look closely, you can see the outline of a stent before the dye is injected. So you could also code a patent stent in the left circumflex. And then there is some left main disease, but I thought it was less than 50% based on the angiographic appearance. So I said insignificant left main stenosis. So someone asked about the OM in the circumflex, and I think, you could, there is probably some mild disease in the OM, but I thought it was less than, probably not really the focus of the angiogram, so I try not to overcode in general, so. So here's another case. Go ahead and take a look at this. This first view on the left is an areo-caudal view. The ribs are going down and to the right. And then an eleo view on the other side. So the first thing, obviously, your goal is to identify where is this graft going. And I think the most helpful view is probably, I would say probably the eleo view is the most helpful for that for me. I feel like that separates anterior, lateral, and inferior the best. All right, so this is a bypass graft to the OM branch of the circumflex. And you can see that because, for one thing, this is the lateral wall on the areo view. But also, if you look at this eleo view down here, you can see the outline of a calcified left circumflex where the LAD would go. And this is just where you would expect an OM. It's kind of an anterolateral distribution. There's a severe stenosis in the graft, and I think this is likely due to thrombus. There you see this filling defect inside the graft. So I would code that thrombus is present because you see these white circular objects in there, so it's an actual filling defect. And then you can infer that the circumflex is occluded here because you don't see any retrograde flow back into the circumflex. Here's another case, a 60-year-old man, and sometimes you will get a question stem. So here's a 60-year-old man with previous PCI and acute onset chest pain. Okay. All right, and we'll go ahead and, so in this case, the key thing here is that you have occlusion of the LAD. You can see, and I think you can see this pretty well, that there is a stent there in the LAD. So always look for that when you're looking at these angiograms. Is there a stent in there or not? And so this is a case of stent thrombosis. So you should infer when you see an abrupt acute occlusion of a stent that that's stent thrombosis, especially in a patient with acute onset chest pain. And so for this, I would code thrombus in the LAD, occluded stent, and you could either do severe stenosis or complete occlusion of the LAD. I wouldn't code any mild disease in this case, so there is some mild proximal circumflex disease, but again, trying to just focus on the main findings. All right, here's a still frame. This is the only picture that you'll get for this case. And what would you code here? All right, so this is a little bit tricky because it's just a still frame. But the appearance of this fits with a bypass graft because there aren't branches coming off of it. So this is the LAO view. You see the ribs going down to the left. So this is in the area of the right coronary artery, but you don't see any branches coming off of it. And also you see this other vessel in the back here that looks diseased and really small that seems to be filling retrograde. So this is a bypass graft to the right coronary artery. You can see this is the inferior wall, so that's probably a right PDA. and there's a severe stenosis in the bypass graft. So that's all I would code for this case. You could also code occluded RCA. I think that would be very reasonable to code here as well, because you don't see the contrast going up as well. All right, here's another case. I'll give you another 10 to 20 seconds here. This is probably a little more tricky, so just orient yourself to the view. So this is an LAO view. You can see that the right coronary is being injected. There is disease in the right coronary artery, probably moderate disease. There is at least 50% narrowing, but it's not greater than 75. And it's supplying the inferior wall here, so it's a right dominant circulation. Then you see this other vessel, though, also coming off right where the right coronary is. So that's a sign of a coronary anomaly. And it does have a pretty long branchless origin as well, which is a sign of an anomalous circumflex. The other big thing here, which is very tricky, and you probably won't get this on the boards, is that there's also a stump here off of the circumflex. So this is a patient that presented with an acute coronary syndrome, and this was an abrupt occlusion of the OM in this case. So anomalous left circumflex, complete occlusion also in the left circumflex, and I also would code moderate disease in the right coronary artery. So when you're coding anomalies, you won't have to say whether it's an anterior or posterior course for the boards. All you have to do is identify which territory it's going to and that it is anomalous. Here's another case. There's an ariocaudal view, and on the right here is an LAO cranial view. Right, and so for this case, there's a lot of things, but I coded a complete occlusion of the LAD. See that the LAD does not fill at all in the mid-segment, and then you can see it filling by collaterals. So I did say the LAD is filled by collaterals from the diagonal. You see this big diagonal coming down and filling the distal LAD. And there's also severe stenosis in the left circumflex. And you see that best in this ariocaudal view. You see the distal circumflex has a very severe stenosis. And you can differentiate the two vessels based on the movement again. See, the LAD has different movement than the arteries that are on the lateral wall. There's a question about thrombus versus severe, and there wasn't anything in that case that made me think about. First, I didn't give you a question stem about acute coronary syndrome, and there weren't any findings necessarily that would suggest thrombus. There was calcification also in the LAD where it was occluded, and it ended kind of, there was kind of this abrupt narrowing, and it kind of had a very small lumen, and then it completely was occluded. So that was more, looks more like a chronic occlusion, so I wouldn't code thrombus in that case. Here's a 55-year-old diabetic woman who presents with an N-STEMI. Okay. All right, so this is two views of two different arteries in this same patient, so there's a lot here. You have an ariocaudal view on the left of the left coronary and the right coronary. So for this patient has three vessel disease. So they have a severe stenosis in both the LAD here. This is where the LAD comes off. A severe stenosis in the left circumflex, and then also the right coronary is severely diseased proximally as well. There is left main disease, but it's less than 50%, so you could also code insignificant left main stenosis, but that's not really the focus of this. All right, here's another case. RAO view here on the left and LAO view on the right. Let's see if you can get this one. All right, the key here is fistula. So we didn't tell you that the patient had a continuous murmur, but if the question stem mentions that they have a continuous murmur on physical exam, that'd be another clue. But here you see that there's an unusual branch coming off superiorly from the LAD, and it's going to an anterior structure where the pulmonary artery typically will lie. And you see it again in the LAO cranial view as well. You can also code that there's insignificant disease in the left main and LAD here. So this is one that you should be aware of. This is one of the more common fistulas that we will encounter in clinical practice. All right, this is another coding case here, and specific pathology. Getting a little bit lower on time here, so I'm going to go ahead and tell you that this is myocardial bridging here. You see systolic compression in the mid-LAD. But otherwise, there's no other disease present. And here's a postpartum 32-year-old woman who presents with chest pain. Whenever you see postpartum, think about spontaneous coronary dissection. And you can see here that there's linear lucency in the distal LAD, almost a train track type appearance, and that's indicative of dissection. So I would say severe stenosis of the LAD in this case, and dissection. And another case, 84-year-old man with unstable angina, and there's this filling defect in the mid-right coronary artery, and intracoronary OCT showed that there's evidence of what looks like thrombus. Calcification would not have this dense appearance to it and would have more shadowing. And so I coded severe stenosis and intracoronary thrombus. So whenever you see a discrete filling defect, think about thrombus, especially in a patient who is presenting with an acute coronary syndrome. All right, and here's another case. Go ahead, and I will let you code this one. So go ahead and take 15 seconds to code this. All right, and this is the obligatory normal coronaries. So, good. So you gotta keep that in mind. If you're looking and you're not seeing anything, the other thing is this patient has palpitations, so you may not be expecting to find coronary disease necessarily in this patient.